Now we are going to move ahead to our local panel, and this panel will give us a close-up look at the issue here in Hawaii, of course. And to moderate this panel, we have Mr. Kurt Kendro, who is retired from the Honolulu Police Department, and he served a number of years as the Traffic Division Major, so he is very familiar with Hawaii's drugs and driving problem. And Kurt and I go back a long way, so it's an extreme pleasure for me to have him come up and moderate this panel. Kurt.
Thank you so much, Carol. Good morning, everybody, and aloha. I got to share just two quick stories because this building is very special to me, actually. I'm originally born in Mishawaka, Indiana. Hoosiers, go Hoosiers. But my family moved here in 1965, and my mother worked for the Hawaii Medical Association, which was actually in this building when we moved to Hawaii in 1965. So I was brought here as a baby, 2 years old, and they used to babysit me. All the women in Hawaii Medical Association used to babysit me in this building, and I used to play all over this building as a very young toddler. So it's amazing to see what it looks like here inside of the Mabel Smythe, what I know as the Mabel Smythe building, here all these years later. And it's been a lot of years since I was that small again, since 1965. You can do the math. But it's wonderful to be here this morning. The other story I wanted to share was as a young police officer, somewhere around 1988, I want to say 1987 probably, I was known to make a lot of DUI arrests, and when it was known as a DUI versus the OVUII. I arrested a woman driving all over the Alawai Boulevard, and she swore to me up and down she hadn't been drinking, but she looked like a drunk, talked like a drunk, walked like a drunk. Got her in, she blew triple zeros. In police officers' terms, that's no alcohol involved. And she looked at me straight in the face and said, "You see, I told you I wasn't drunk. I've been taking drugs. I'm taking all of these different prescription drugs." Wrote out her confession on all the drugs that, after I Mirandized her, wrote out her confession to all the different drugs that she took. But we didn't have a mechanism in place for DUI drugs or OVUII drugs at the time. So as a young police officer, it was one that I wanted to see something like this because I knew early on, all the way back in 1987, that this was an issue. And so it's wonderful to be up here all these years later, although I am retired now from the police department, which is really nice, by the way. I'm glad I survived for 30 years, but I still try to do my part with Mothers Against Drunk Driving. I worked with Carol when I was still in the police department working on the mandatory blood draw law a long time ago when I still had hair. So it's very, very good to be here this morning. We have a great panel that's going to share with you the things that are going on locally in Hawaii. We've got a national perspective with our three speakers in the previous presentation, but now we want to know really what's in Hawaii and how does that affect us, because this is our community, this is where we grow, where we all live and thrive. So we need to know what's going on in our local community. Before we do that, I'd like to invite the birthday boy up here to give us a little bit of a demonstration on what he does and how it affects all of us and some good things. I'd like to introduce, wherever you want to do it, Anthony Mendez, please.
How you guys doing?
Oh.
Thank you. My name is Anthony.
There we go.
My name is Anthony Mendez. I'm a substance abuse counselor here in Hawaii. I worked at the high school level for about 10 years. One thing that I know to be true is the kids aren't going to change. Every time you come in, the same attitude. If you can imagine what it was like when you were a teenager, it's pretty much the same thing. The thing is, as adults, is we have to start changing our attitude. With the laws that are changing and things that are coming up, I want to give an example. I've created a curriculum, and I teach it through the Department of Health, and I use games to engage kids into treatment. And if you would indulge me for a moment, if you just go ahead and put everything down that you're holding, and just cross your arms for a minute. And I want to give you an example of what it's like to change. We're so used to doing things a certain way, and when we cross our arms, imagine this is like what we do in our daily life every day. We have our ideas of how things should be. And just because we have our ideas how things should be doesn't mean it needs to be that way. So an example of how things are and how uncomfortable change is, what I'd like you to do is look at your arms, and then I want you to reverse it. Do exact opposite of what you're doing now, and just hold it there. Now, how comfortable does that feel? Does it feel comfortable? No? Right. So by a show of hands, who thought that was awesome? It was comfortable, it was perfect, no problem. All right, and for those, how much of that was uncomfortable? It was a change. Right, the other one that I like to do is just go ahead and have your hands like this. And then when we think about change, think about 1 degree of change. So just move your fingers up by 1. Now some people, yeah, that's no problem, but others, it just feels weird. Now the thing about change is it's not gonna take place until you decide to make the change. So every day we have to decide to change our minds about things. And I'm not suggesting anything. What I'm saying is just change a little bit. If you hold it here, if you've undid your hands already, that's your tolerance for change. So I ask you, with these laws changing the way they are, we're not going to be able to change these laws, and we're not going to change how many people drink and drive, but what we can do is we can change our ideas of this, and we can explain this to our youth. We can explain this to people and have them really identify why it is that they do what they do. Because telling people that it's bad, they know it's bad. People that drink and drive and do drugs and drive, they know it's bad. We all do. And how many of us in the room have done it before? I'm not going to call you out, but I'm sure quite a few of us have, especially if you're a counselor in recovery. So what I'm saying is, that's the thing that we have to do. Some of the attitudes that people have towards the laws changing for marijuana, it's understandable. And at the same time, if we go to it with that same process, we're just going to be hitting our heads up against the wall and not making these changes. So I ask you guys today, just have that 1 degree of separation and starting to change attitudes. Thank you.
Thank you so much for your confidence. And we certainly are in a changing society, especially in our own community within here. So I'd like to introduce, or have our panelists introduce themselves one by one, so at least you know what their background is, this multidisciplinary panel that will give us each a little bit of a different perspective of what's going on out on our streets. So joining us from the Drug Enforcement Administration, Brian Bonifant. If you could go ahead and introduce yourself and tell us a little bit about yourself.
My name is Brian Bonifant. I'm a Supervisory Special Agent with the Drug Enforcement Administration here in Honolulu. Just to give you a brief overview on DEA and kind of what we do, DEA is divided up into 2 divisions: an enforcement division, which targets the criminal element, your meth, heroin, and cocaine dealers, and a regulatory division, which manages the doctors and pharmacies and veterinarians and anyone else that can prescribe controlled substances. And also under our, recently, probably within the last decade, under the regulatory section, because of the opioid crisis that most of us are aware of, DEA created a tactical diversion squad, which takes members of the enforcement side with law enforcement powers and pairs them up on our regulatory side to target doctors and other persons that are able to prescribe medications and target the illicit distribution of those controlled substances.
Thanks, Brian. I don't know, can everybody hear him? I'm not sure if the audio, the AV people can maybe make sure the microphones are good. Thanks, Brian, appreciate it. From the island of Kauai, a good friend of mine there, Mr. Justin Kollar, prosecutor for the island and county of Kauai.
Good morning and aloha. Thank you, Kurt, for moderating this panel, and thank you, Carol, and everyone at MADD for putting it together. My name is Justin Kollar. I'm the prosecuting attorney for the county of Kauai. Midway through my 2nd term, I've been in the position for about 6 years. Came to Kauai in 2008 to work as a deputy prosecutor in traffic court, which is where I got to meet many of the people in this room through my work prosecuting DUI cases. Before that, I clerked for a wonderful judge on the state of Hawaii's Intermediate Court of Appeals named Dan Foley. And before that, I worked for the city of Boston in their legal department doing different things. So go Sox. And I didn't say Yankees suck. I'm thinking about it. So yeah, I'm really honored to do the work that I do. I still prosecute impaired driving cases, mostly vehicular manslaughters and negligent homicides these days. But yeah, I'm very passionate about this issue.
Thanks, Justin. Longtime friend and not only a fellow police officer, but a fellow torch runner and volunteer in Special Olympics. I'd like to introduce Captain Benjamin Moszkowicz. Ben?
Good morning. I am the captain of the traffic division at the Honolulu Police Department. My boss is here. He's keeping a close eye on me this morning. But the major and I are basically in charge of a division of 117 sworn and civilian employees, all that work for the Honolulu Police Department. Our division is divided into 3 sections. We have an enforcement section. Those are the solo bikes who give you speeding tickets, and the DUI guys who drive around at night and make DUI arrests. And then we also have an investigative section, the vehicular homicide section. The VHS, we also impact you fairly recently and fairly regularly lately. We go out and conduct investigations anytime there are critical or fatal motor vehicle collisions, and we're on call for that 24 hours a day, 7 days a week. And then the third part of our division, which goes widely unnoticed but also impacts you by saving you tax money, is we are also in charge of the parking enforcement and collection section. So the officers who go out, yeah, $30 a pop. That doesn't go to the city, though. That goes to the state. What does go to the city is all those nickels, dimes, and quarters, and millions of dollars, believe it or not, that they go out and collect and repair meters and unfortunately issue parking tickets at the same time. So prior to being a captain, I was assigned to the traffic division as a lieutenant, before that as a sergeant, and before that as an officer. So the majority of my 18 years in the police department have focused and kind of centered around this Death Star, so to speak, of traffic safety and impaired driving. I've had the opportunity to attend trainings nationwide, and I was certified as a drug recognition expert and a drug recognition expert instructor since 2003. So I've participated in training on all 4 counties, state officers, probably hundreds and hundreds of police officers, training them both in the detection and apprehension of alcohol impaired drivers, as well as the detection and prosecution of drug impaired drivers as well.
Thanks, Ben. Yeah, long career in traffic enforcement and impaired driving. Our next panelist, I met some time ago, and just know him as Mr. Stats, because if you need some stats, this is the guy to go to. But Mr. Dan Galanis, or Dr. Dan Galanis.
Also known as Mr. Excitement, just throwing that out there. Yeah, I'm basically the data guy from Department of Health, asked to come here and sort of give a local perspective on how we understand these issues in Hawaii.
And another expert in the area of substance abuse and treatment, Mr. Eddie Mersereau.
Yeah, hi, Eddie Mersereau with the Alcohol and Drug Abuse Division, Department of Health, and just want to give a shout out to my prevention staff and interns. All of the ADAD staff, raise your hand. Yeah, we're here in force, peeps. And so yeah, I've been in the position for about 3 years now. It feels like it's 30, but still loving it. And that's all you wanted to say, Dan? Just a little bit? Okay. Mr. Excitement. Glad to be here.
ADAD has a long reach with the Honolulu Police Department. I worked with them some 15 years ago when I was in the juvenile division. Very, very positive influence on a lot of the programs that we had. And good to have you here this morning there, Eddie. You already met Anthony, but if you could just give a little bit more background about where you come from, if you want that on there.
See, I've been in Hawaii 25 years, been a drug counselor since 2008, so 10 years now. Wow. All the time in high schools, Wailua High School and Kaimuki High School here in town. I worked heavily with the kids in Palolo in public housing, heavily with the Micronesian population.
Thanks so much, there. So to start it off, before we actually get into the panels, and I should, well, even before I say that, this whole presentation is going to be driven by your questions. Now, I'm going to start us off with a couple of questions just to open it up with each of the panelists so that you have some idea a little bit more of what they do and how they do it. But all of the questions need to come from our Slido. So if you're not logged on or have a neighbor that can help you to get onto Slido to ask those questions, your questions are going to come to Karen and Carrie down here in the front row, and they're going to come up on the board for you, for the panelists to answer. So we'll direct them towards the discipline that would best answer those questions. So please, please, please log on and send your questions in that we can answer. But they're going to give, they'll answer some, I'll have some questions that give them at least a little bit more background that you can understand where they're at and where we're at in the community. But before we start all of that, like I said, Mr. Stats over here, Mr. Data, he has a presentation that basically tells us our overall perspective of what's going on and what we can see that affects all of us, that it will relate to everything that we talk about here today. So, Dan, you want to come up? We can call up his PowerPoint.
It's on, I believe, yeah. Okay, great, thank you for that. I often say this is probably the most important slide, even though the next, say, 9 minutes is going to feel like an hour. This is, if you have any, trust me, I'm just scratching the surface with what we're going to go through, but if you have any more pointed or things that weren't covered, please feel free to contact me and we'll try to work from there. So I do work at DOH. This is an overview. Basically, we have 3 sources of data that we're going to look at. FARS, which is the national data, which Dr. Hoff sort of described a little bit this morning. The trauma registry data in Hawaii, which is essentially people who are hospitalized for injuries in the state. And lastly, this, I think this is unique to Hawaii. We've got medical records from all the acute care hospitals in the state that was gotten through Hawaii Health Information Corporation. And they also brought in the laboratory toxicology data to link with those records. So it was, it was a big boon, but there's also big limitations to all this. And Dr. Hoff already talked about it, as well as Mr. Chief Spicer. I'm sorry, I just ruined that name, but the gentleman from Colorado. But the big limitation is the non-testing. So even though I think this is the best data we have available to us, you always kind of have to keep that in mind. We only know the information from people who are tested. So real briefly, the FARS data, Hawaii versus the U.S. I don't know where this mouse is going, but so basically, among fatally injured drivers, Hawaii's on the left, and about 20% were positive for illicit drugs. So it's slightly higher than the 13% for the rest of the country, but there are a lot of unknowns. This is among fatally injured drivers. But that unknown component goes up quite a bit when you include all drivers involved in fatal crashes. In Hawaii, it's on the order of 54%, which is actually lower than the rest of the country. And then within our state, most fatal drivers are tested, but 28% are still not. And that's about the same for Oahu and neighbor islands. But when you get to the drivers who survived the crash, 72% are not tested specifically in city and county Honolulu. So they're doing a much more testing on neighbor islands. So already we have sort of a within the state bias in what we know, with Oahu kind of lagging behind. So basically we are sort of one of the higher states in terms of illicit drug impaired drivers. Hawaii was 8th overall. But this kind of comparison is really limited by, testing is all over the place around the country. We're actually not bad, this sort of half of drivers who are tested, when compared to, say, states, North Carolina, where there basically doesn't test anybody. So Alaska is the highest, but they test the majority of the drivers. So really kind of hard to make sense of this kind of data. But we do see these sort of, whether we're talking about fatally injured drivers or all drivers, we do see this peak in Hawaii in the red in these younger age groups. Our target audience here today, ages 16 to 25, and the group immediately next. So what are these illicit drugs we've been talking about so far? It's essentially, in the FARS data, it boils down to cannabis and in Hawaii, methamphetamine. Cannabis is more prevalent than methamphetamine for all ages, but that kind of changes when you go across the age range here, where methamphetamine use becomes more predominant in this is my age group here, in older drivers. And I think this is unique to Hawaii somewhat. This is really kind of I hate to say it, but sort of the meth cohort in the state, I think, that perhaps has been using for decades, going back to the 80s, and you see these manifestations as cumulative effects by the time you get to whatever age group I am. It's not even middle age anymore. It's AARP eligible, I guess. But among youth, I think we heard, I think Dr. Hoff said this, that it really is, marijuana is more predominant in use. So that was the FARS data. The trauma registry, just to tell you, describe our trauma system real briefly. It catches most of the major trauma in the state. It's Wilcox, Maui, so Neighbor Islands is in here too, 3 facilities on Big Island, and of course Queens. We have very up-to-date records through June of this year, but the issue again here is among these patients, only about 40% had a drug screen. And that's actually not bad, but you can still see it's less than half. And that varies by the facility. Queens does a lot of testing, by patient age group, by gender of the patient, by the mechanism of injury. Fortunately, most of those who are injured in crashes get tested. Overall, these are patients of all injuries, what they tested positive for. And again, THC is probably the highest. Overall, about 11% were positive for illicit drugs of some sort. I'm going to skip this slide. So the patients who are injured in traffic crashes, this is the toxicology results. Overall, 20%, this is basically patients who are hospitalized, 20% were positive for illicit drugs. Again, we have this gray area, 37% who weren't tested at all. But at least 1 in 5 were positive for illicit drugs after being injured in a traffic crash. That's 19%. Where's my cursor? Here we go. So that 19% is a little bit, it's higher among car and truck drivers, a little bit higher still among motorcycle, moped drivers. Surprised to see 18% of bicyclists. 16% of pedestrians and 15% of passengers. So pretty much everyone out there in the roads, which of course is a reflection of basically everyone in society. So 20% overall positive for illicits. It's actually higher for this younger age group, as you would expect. And broken down by gender, males are more likely to be positive than females. And that's true pretty much for every age group. But again, this is sort of the peak age we're seeing here, 16 to 25. And these are the substances. Once again, you see that same pattern we just talked about with FARS, predominantly cannabinoids for this younger ages, and almost equal amounts methamphetamine by the time you get over here to this age group. Okay, so lastly is that database I was talking about with all hospitals in the state, and we linked that to both at the emergency department level and hospital admissions. We linked it to the data from DLS and clinical, et cetera. And you get to pretty staggering numbers of data to work with, of people, injuries that are discharged from the emergency department and injuries requiring hospitalization. Over this many years, we have 600,000 records, mostly in the ED level. So things are looking good, but what happens is only 6% of these patients are ever tested. And I believe, but that's about 20% if you get admitted, but still, there's a lot of non-testing going on in the state. And again, it varies by hospital. much more likely to be tested if you're admitted. Males, once again, more likely. Interesting to me, if you have Medicaid or some other income qualifying plan, you're more likely to be tested, 8%, than if you have private insurance such as HMSA. And it's really low testing across the mechanisms of injury, with the exception of patients who are injured by self-inflicted injuries or suicide attempts, which makes sense. Let's see, I'm going to skip that. So again, so these are the tox results for patients injured in traffic crashes. Overall, only 2% of those who are discharged from emergency department, that's the bulk of the injuries, were positive for illicit substances. But again, we come in at that about basically 1 in 5 of those who are admitted were positive for illicits. And here, once again, the motorcycle moped drivers, this estimate is about 1 in 3 were positive, slightly less for people driving cars and trucks. And very similar again when we look at age and gender. You once again see this peak and see that it's more prevalent among the males. And again, very similar with the predominance of cannabinoids in the younger ages. And meth, and surprising to me, but cocaine is actually nearly as predominant as meth from these data. I thought cocaine went away in the 80s along with my youth, but apparently it's kind of making a comeback. I don't know, I can't keep up, but I see some nodding heads in the audience, so yeah. Okay, just to sum up, the FARS data, again, with all these limitations in mind, I'm going to say 1 in 5 drivers at a minimum. Again, we have to stress this is minimum. We're positive for illicit substances. Registry is telling us slightly more, but again, they test more. And really a THC problem predominating in the younger drivers. And this hospital billing data, big limitations with non-testing, but again, it's really pointing towards motorcycle and moped drivers and also drivers of cars and trucks, about 1 in 5. Should we just go on with the rest of the panel, or? Okay, great, thank you.
So again, if you have questions, excuse me, specific to what Dan presented, please send them in by Slido. Karen and Carrie are already putting questions together that'll come up and will be up on the board as we go forward. So they are already receiving the questions. Some points there, interesting points there. Methamphetamine use, we've seen it since the 80s. I saw it first in 86. We saw prostitutes in Waikiki awake for 3 or 4 days because they would be high on meth and, earning their money on the streets, but they hadn't slept for 3 or 4 days. And that was the earliest exposure that I had in my career. And in the 90s, when I was working on my master's degree, we saw that there was no aging out cohort, as Dan had pointed out, of those offenders for methamphetamine. It was across all the ages. So cannabis certainly, but methamphetamine is certainly a crystal meth, especially in Hawaii, certainly still has an impact in our community. So what we'd like to do now is basically I'm going to start off the panel with some softball questions about what they do and where they're at, going with the disciplines before we start taking the questions from the audience. So we'll start with our friends from the DEA over there. What's coming into Hawaii? How's it getting here, and what do we see on the streets?
Meth is the hot topic. I mean, that's the predominant drug.
Can you speak in the?
I'm sorry.
Please.
Methamphetamine is definitely the predominant drug here in Hawaii. By far, we see a lot more of that coming in than heroin, cocaine. Although we're starting to see an uptick in heroin in the last probably 2 years out of the 4 I've been here. But by far, we're seeing large amounts coming into Hawaii for an island that's an end-user state.
So I have to follow that up with, but how's it getting in here? I mean, it's got to come in land, sea, air,
Right.
something. I mean, that's the only way it can get here. Is it being produced locally? I mean, can we maybe?
No, absolutely. So it is not being produced locally. From our best research through our labs on the West Coast, the majority, if not all of the methamphetamine that's coming into Hawaii is produced in Mexico, which have super labs now, which kind of made the shake and bakes of a few years ago obsolete. So the transit route comes from Mexico through California, Nevada, over to Hawaii, and it's various means of transportation, whether it's through the mail, body carriers, your luggage coming over on cruise ships, aircraft, shipping containers, vehicles. Traffickers have a great sense of being sneaky.
Well, that's their job, right?
Absolutely. Keep
One
us
of the
on our
ways
toes.
that I'm familiar with is they bring it in through the docks. The amount of tonnage coming every day off the ships is tremendous.
Right, and that's one of our challenges here, because we are not a port of entry and actually a state within the United States. We don't search, and DHS does not search all of the incoming cargo coming into the state of Hawaii. So it's easy if you're in California, Oregon, Washington State to have a dock worker there throw a couple duffel bags of methamphetamine into a shipping container and then have somebody on this end pick it up.
It's kind of sad, but it's amazing how simple it is, quite honestly.
Very simple.
Thanks, Brian. So let's switch over to Ben over there, Captain Moszkowicz. So the drugs are getting here. We just heard about meth coming up from Mexico through California and through the domestic ports. Makes it real hard for search and seizure issues to, just go through any container whenever they want. But how does that transition to what you see on the streets or enforcement for impaired driving, drug arrests, and how does that compare to those impaired drivers out on the streets?
The trends that you're talking about and the trends that we talked about this morning are exactly what we see in impaired drivers. So when we have a driver that's driving appears to be impaired, when we're falling behind them, a lot of times we can't tell what the impairing factor is. We know something is impairing their ability to divide attention amongst all the tasks required to drive safely. So that is kind of like the logical sequence that leads us to pull the car over, to talk to the driver. We get signs and symptoms of indicia, indicators that people have consumed substances or are impaired in the car. That gives us a field sobriety test. And the field sobriety test, I'm just kind of talking through this logical sequence. The field sobriety test is basically just an indicator of a person's ability to divide attention well. If you can divide your attention amongst all the tasks required for safe driving, you're probably going to do well on the field sobriety test. If you can't divide attention, like alcohol and a lot of these illicit and even legal medications will cause that this dysfunction in the ability to divide attention, then you're not going to do well on the field sobriety test. So the driving plus the impairment leads us to an arrest. The reason I tell you all that is following an arrest for DUI drugs, we request a toxicology sample, either a blood or urine sample. All those people who opt in, we collect the samples and I get the report. So I can tell you that on Oahu, the majority of the cases that we see of impaired drivers who have been arrested for DUI are marijuana. Second only to methamphetamine. Third only to a combination of marijuana and methamphetamine. So those two and those two used in concert are definitely the highest percentage of drivers that we see that are arrested for impaired driving.
So let me follow it up a little bit because Chief Ticer brought it up earlier. So most of the people in the audience know what a field sobriety test is. You've seen it on TV, touch your nose, walk the line, raise your leg up off the ground. But Chief Ticer brought up some terms earlier, DRE, A-RIDE. Can you tell the audience a little bit about what a DRE trained officer is? You're a certified expert in DRE, and what A-RIDE is, so that the audience can understand what the police officer needs out on the street.
Sure. So we take all of our recruit officers when they join the department and we give them 32 hours of field sobriety test training. So we basically teach them how do you make a DUI arrest. And most of that training is focused around the alcohol DUI. There are certain parts that we add in to make officers aware that drugs are impairing as well. But the tests at the roadside don't really change much, whether the driver is impaired by alcohol or drugs. So everybody gets that training. The next kind of step up in the progression is the A-RIDE training that Chief mentioned earlier. So an A-RIDE trained officer is an officer who is experienced and proficient in administering the field sobriety test. So this is an officer who typically has been on the force for some time. They've developed proficiency. They're getting good at it. And then we take them and we kind of enhance their abilities. Not really enhance their abilities. We just tell them a lot more things to look for. We show them a lot more signs and symptoms consistent with different categories of drug impairment. And the reason we do that is not because we're telling them anything they don't know really. What we're doing is we're giving them a basis so that when they're called into court to testify, well, if you didn't smell alcohol, officer, how do you know this person was impaired? Well, I can rely on the training I received in A-RIDE and tell you that I know that because his pupils are dilated, that's an indicator that he could be impaired. I know that because he exhibited certain signs and symptoms in different areas of the test, that those are indicators that he could be impaired. I know that just because he does well, maybe, or his eyes can track or pursue smoothly in an HGN test, that would be a very classic indicator for an alcohol impaired driver. Someone could exhibit no clues, but still be incredibly impaired on a whole host of other substances, including the two that I just mentioned a moment ago, marijuana and methamphetamine and the combination. None of those drugs cause HGN. So A-RIDE kind of gives the officers...
Wait, stop. Most of the people don't know what HGN is.
HGN, horizontal, sorry, cop talk.
Sorry, I'm trying to help
so
you.
So many acronyms.
Sorry, I don't mean to
No,
interrupt.
so the field sobriety test is 3 parts, okay? 2 parts involve divided attention. So we're giving you directions and we're having you do physical tasks at the same time. And the tests measure your ability to divide attention between those 2 tasks, remembering the instructions and at the same time maintaining a physical condition, so being able to divide attention. The third component of the field sobriety test is this test called HGN, or horizontal gaze nystagmus. So the beauty of HGN and nystagmus in general is that everyone has it. Everyone in the room has it, but it's in most of us microscopic when we're sober. What happens is when you consume alcohol and certain category of drugs or certain drugs, it interferes with the ability of the eyes to track a stimulus smoothly. So what the officer will do is position a stimulus, a finger, a pen light, the tip of their pen in front of a subject's face, and they'll move that stimulus left and right in a specific pattern, a sequence of movements. And if the subject's eyes follow that stimulus smoothly, it's kind of like if you imagine your windshield wipers are wet and the window is wet and the windshield wipers kind of smoothly pass from side to side. That's what a normal unimpaired person's eyes look like, or someone who doesn't have HGN. What alcohol and certain categories of drugs will do is it impairs the eye's ability to track smoothly. So instead of seeing a smooth wiper traveling across a wet windshield, we'll see the eyes will jerk and bounce as they travel in a horizontal fashion, hence the horizontal back and forth across the field of vision. So an HGN test unfortunately, Judge, could never tell you this in trial, but I can tell you firsthand, an officer who is good at it can perform an HGN test and tell you the person's breath alcohol content or blood alcohol content very specifically if alcohol is the only impairing substance. If you don't believe me, get my number later. I'll take you to an alcohol workshop. We do them several times a year, and I will prove to you that the officers who I have working for us can, and this is all they do, is DUI stops. They can tell you a person's BAC very, very specifically based only on HGN. And the chief's nodding his head. All the cops and prosecutors are telling you it's true. It's true. The problem is HGN, and this getting back to the A-RIDE training, HGN is not necessarily the be-all and end-all when it comes to drug-impaired driving. And that's where a lot of our officers get really good at alcohol-impaired driving, and we can make a lot of arrests because they're very comfortable with it. So what A-RIDE does is it tries to increase officers' comfort level with drug-impaired drivers. That just because I don't see HGN, don't put them back in the car and send them on their way. Administer the rest of the test, conduct a complete investigation, and take it on to the next step. So it gives the officers a more solid grounding or a more solid footing of how they can explain what they saw, but then why what they saw means something. That develops probable cause, which it gets us an arrest, and that kind of what triggers the rest of the DUI sequence. Briefly, I know that was a very long answer to a very short question. Welcome to the world of DRE and A-RIDE. The DRE officer is an officer who has completed, at least in Hawaii, has completed A-RIDE.
Wait, stop. What does DRE
I'll
stand
get you
for?
to- Thank you, sir. This is good. It's the Ben and Kurt show. DRE is a drug recognition expert. So this is an officer who has been specially trained. They've had an additional 72 hours of training, which is like over 2 weeks. We conduct this training, and basically it's kind of like A-RIDE, but it's way more in depth. We go in depth into each drug category and talk specifically about why certain drugs in certain categories produce observable signs and symptoms. We talk about a whole host of physical tests that we do. We teach officers to measure blood pressure and look at pupil size, which are not difficult things, right? We all do that. We put 50 cents in the machine at Walmart and it'll check your blood pressure. It's not a scientific, highly technicalized test, right? You trust the blood pressure machine at Walmart. You should trust an officer. A person can be trained to measure blood pressure. So we do those things. We teach them to check blood pressure, look at pupil size using a little card, a pupilometer, to compare the size of people's pupils to give an actual number to the diameter of the person's pupils. And that's kind of what leads us to different clues and cues. And we can teach the officers who become DREs to conduct this 12-step standardized systematic evaluation. It's done as much as possible the same way every time. And at the end of the evaluation, or during the evaluation and at the end, they answer 3 questions. The first question is this person impaired or not? And if the person is not impaired, then they're out. They're gone. Give them back their license, set them free, give them a ride back, send them home, call them a cab. The second question, if they are impaired though, is that impairment due to alcohol or drugs or medical condition or something else? We do train the officers to look at a variety of medical conditions, the symptoms of which can imitate or very closely resemble alcohol and drug impairment. And if it is a medical condition, then we get the person medical treatment and we get them help. Obviously, we don't throw them in a cell and convict them of DUI. But if they are impaired, and if the impairment is due to alcohol or drugs, then the DRE will form an opinion as to what category or categories of drugs is causing the impairment based on the signs and symptoms that they observe. Then that opinion kind of guides the toxicology later on.
So thanks so much. So that's the decision-making factor to make your arrests. About 5,000 impaired driving arrests across the state, roughly per state?
Just HPD. Statewide, I think we're a little over 7,000.
Okay, 7,000 impaired driving arrests over the entire state. So from the arrest stage, it's going to go over to our prosecution side. So Justin, what are you seeing in the courts? What do you see as far as impaired driving, negligent homicide types of cases, and what are you seeing in the types of drivers in the court system?
Well, from what you just saw from Captain Moszkowicz, we see a lot of this. I mean, DUI trials can take days because, in each case we have to go through the whole litany of the training and why does this mean that, and what does that tell you about this driver, etc. So those trials can be very time consuming. So, in an average district court calendar, folks who have spent time in court know that we get, dozens, if not hundreds of cases a day through an average district court courtroom. And so to tie one of them down for 2 or 3 days to do a DUI trial can be difficult for prosecutors, for defense attorneys, and for judges. That's just one of the challenges that we see on the prosecution side when we're trying these cases. Most of them do settle, as is typical of most cases. If the police officer does a thorough and complete investigation, and if I get an officer like Ben here who's doing the report, the defense attorneys know which are the good cops and which are the cops they can crack under cross-exam. So most of the cases do settle, and we do tend to get most of our cases from the cops who really want to go out and do DUI enforcement. Some cops, that's not their forte. They don't do much of that. But other cops, that's their bread and butter, whether they're in a traffic unit or in a normal patrol unit. So they get very proficient at doing those investigations, at writing those reports, and at laying the groundwork for us to get a successful plea rather than having to, pour a ton of resources into doing a trial. One of the big challenges we face in Hawaii that's a little bit unique to us because, of course, we're an island state is the issue of the toxicology and the lack of adequate laboratory facilities to test the blood and urine samples. On Kauai, we're essentially a no refusal jurisdiction, meaning that if the police officer makes the arrest, asks the person to take a breath or blood test, and the person declines, we will go and get a search warrant. We'll call the judge in the middle of the night. We will get that search warrant. We'll take the person's blood involuntarily and send it for testing. But in cases where we do that, we have to send it to a laboratory either here in Honolulu or on the mainland. Particularly in DUI drug investigations, if there's complex screening or we're looking for something that's a little more esoteric, maybe a synthetic or something like that, that would have to go to a lab on the mainland. So, you know, we haven't yet been put in a situation where we've had to spend all the money to bring out all the technicians to testify. But, you know, for a petty misdemeanor case, we're looking at spending, you know, upwards of 10 grand to prosecute a case where the guy's going to get sentenced to pay a $250 fine. So those are some of the dynamics that we deal with being in an island jurisdiction and even being in a rural jurisdiction on the neighbor islands. But so yeah, volume, cost, and also, you know, these DUI cases, they are the type of case that really can catch anyone in the community. You know, a lot of crimes are committed by a very small percentage of the population in the community. We see them over and over again. They're very familiar with the criminal justice system. They're people that have track records that you know, it's a very different demographic from what we get in DUI cases, where you could get a public official, you could get somebody who's well known in the community, a professional, and they're going to be more inclined to spend a lot of money trying to defend their case. So, you know, for them to drop 10 grand on a defense attorney to come in and handle their DUI case is something that's going to be worth it for them. So there is a lot more litigation in those cases in terms of pretrial motions, motions to suppress, motions to dismiss. And, you know, we've built a body of case law in Hawaii over the years as a result of that, you know, I'm sure Justice Levinson can jump in and tell me if I'm wrong here, but, you know, the state of Hawaii has a constitution that provides rights to privacy that go beyond what is provided by the United States Constitution. So we have all kinds of additional protections for citizens, which is a good thing, but also can create headaches for us in law enforcement, because a lot of things that people can do on the mainland in law enforcement, we can't do here in Hawaii. So from time to time, we will have an enterprising defense attorney that comes up with a novel theory, and you know, the appellate courts will bite on that, and, you know, we'll have to go back and kind of change the way we do things. And then we'll have to huddle with our cops and say, okay, you got to go change your implied consent forms. You've got to go change the way you ask the people the questions. You've got to change the way you administer the breath tests. You know, it's an awful lot of work to get to the petty misdemeanor conviction. So we do face some hurdles in Hawaii that when we talk to our colleagues on the mainland, they say, oh my God, I'm so glad I don't practice out there. You know, but at the end of the day, it's worth it. We're going to keep doing it. We're going to keep prosecuting these cases. These are important cases. You know, I tell people that every DUI case is, you know, only by the grace of God is not a murder case or a manslaughter case, and that person was lucky to get arrested for DUI before they killed somebody. So we are happy to keep taking on those challenges and working with folks like Ben who are out there in the streets doing the hard work. Ben, are you still out there in the streets doing the hard work? Are you captain now? No? Okay.
He's still out there.
Ben's subordinates who are out in the streets doing the hard work while he does the glamorous panel discussions. Yeah, free water. This is good stuff. Yeah, no, that's a part of the landscape we deal with, but at the end of the day, it's a challenge we're happy to take on.
So now we go from, you know, the legal side, the process of how they get through the courts and get out of the courts. And on the other side of the coin, we got the prevention, intervention, education side. And Eddie, can you tell us about your side of the coin there? And what do you see, opioids and whatever else is going on through your side?
Yeah, you notice both of them are like turning their mic. Yeah, so the prevention education piece, and I was really interested to see the presentations earlier today, and the media campaigns that are being done, like in New Mexico. I think those are amazing, and I think that part of what our focus has continues to be is to do that, the public education and the public awareness. And one of the things, and Anthony was talking about this a little bit earlier, one of the things is that we're really looking at how we can change paradigms, because in order to move the needle, we have to move the way that people think about these issues, right? And what I've seen kind of in the time that I've been in, worked in substance abuse and this profession, is that the pendulum swings back and forth often from a very much public health focused perspective. We need to, this is a disease, we need to get people help for it, to a very primarily law enforcement perspective. We need to do interdiction, we need to arrest people, we need to do that kind of stuff. And what really this needs is, it is true that substance abuse disorders are a disease and people are at risk for it. But, my perspective is that we have to have that balance, that public health, public safety balance, in order to really move the needle on this. And if somebody has alcohol use disorder or is an alcoholic, we need to give them treatment, but if they drive drunk, we need to get them arrested. And one of the things that for me is kind of, when we kind of conceptualize substance use disorders as a disease, as a chronic illness, in my opinion, a communicable disease, if we look at kind of how substance abuse spreads from generation to generation in communities, we have to take that public health approach. And the public health approach really is epidemiology, looking at what are the causes, how do these things sprout, how do these illnesses sprout, and then intervention and early screening. We do that with HIV and AIDS. We do that with other chronic illnesses. We also look at kind of the idea that the drugs that people are using are really kind of the symptom of the illness, just like the use of tobacco is a symptom that causes or is a causal factor of lung cancer. And so we've been very successful across the nation in reducing tobacco use because of those issues. The thing that makes substance use disorders a little bit different from other chronic diseases, in my opinion, is that they do, people who make the choices that they make around this illness, oftentimes those choices really do endanger the public safety. And that's where I think the real importance of the balanced partnership and collaboration of public health and public safety really is important. And I think I've seen a lot of that stuff, and really been grateful to be a part of a lot of it in the last 3 years that I've been in the position. But really it just comes down to, we really got to start to move the needle on how we intervene, do the early screening. Dan was talking about that drug screenings in the hospitals for traffic injuries are not necessarily universalized, right? And those are the kinds of issues, those are missed opportunities to do an intervention for people who might be at risk for driving under the influence again, or continuing to kind of have their disease progress as an illness. So I Uber dork on this stuff all day long, all night long, so I'll stop talking now. Thank you.
And very different. We have to understand it's very different from a medical model versus a law enforcement model or criminal justice model, right? That Constitution thing gets in the way a lot for a law enforcement side. That Fourth Amendment, that search and seizure thing, really gets in the way about testing. But from a medical model and what the hospitals do, completely different goals, completely different end goals. So they conflict at times, because the medical side wants us to do the law enforcement side, but what they can do, law enforcement can't necessarily do. Would that be a fair?
Yeah, I think that's fair, and I think that's part of the paradigm shift, right? Because it's like, we tend to look at it as an either or, and I think that if we look at this as one of the few chronic illnesses out there that we're dealing with, I mean, if you compare it to things like diabetes, to cancer, those kinds of things, those are all chronic illnesses, just like substance use disorders. But again, the difference is that the activities or behaviors or choices that people engage in when they are suffering from that illness, or when they're at risk for, or they're progressing into that illness, really do endanger the public safety. And so that's where I think that the coordination between public health and law enforcement is so important to really moving the needle on this issue in our state, in our nation. And, the opioid crisis is an opportunity for us to do that because for the first time we recognize that people become addicted, not necessarily always because they want to or because they're bad people. And, they've been taking prescriptions that have been prescribed to them by their doctor. And the issue of integrating those approaches of the medical model and the public safety prosecution model are things that we really got to consider together, right? We got to stop being on two sides of the coin.
Absolutely. Thanks so much. So
Can I jump
Anthony.
in with one thing really quickly on what Eddie said there? If looking at it from a public health perspective is extremely important because a lot of the people we are seeing in DUI cases, especially DUI alcohol cases, are people who are hardcore alcoholics. These aren't people who blow a .085 and they had a couple beers and, if you or I, were at .08, we would be in pretty bad shape. We might not be able to get in a car and start it. Our average BAC last month was .20. So we are seeing people who are, in our DUI arrests, we are seeing hardcore alcoholics who need treatment for their disorders because if we caught them that one night driving at a .20, they've done it a million other times. And so what Eddie said is absolutely right.
Ben, what was your highest BAC?
I don't know if it counts. I had a .52. Yeah. Was an elementary school teacher. She was on her way to work, morning rush hour traffic, maybe 10, 11 years ago. She stopped in traffic on Honolulu Freeway and she got rear-ended. So she didn't even rear-end the person in front of her, but she got caught because the police showed up and said, "Oh, I think that lady's drunk." So we put her on we have this portable, it's called a preliminary alcohol screen. It's like a handheld breathalyzer that we use in the field for screening alcohol factor, not a factor. We thought it was broken because it kept saying 400, 400, and none of us knew what that meant. And we later learned that that's the max. Anything over that, it just reports as 400. So it wasn't until we got the blood test results back later that we knew why the pass kept saying 400. She's 5'2".
These are things that cops remember. Mine was .57.
6.5
Guy
times
driving
the
and
legal
killing.
limit. Yeah.
So, Anthony, I got a preteen daughter. I really want to know what you know because, number one, she's a daughter, and number two, I'm a retired cop, so she's my daughter. So, what are you seeing with the youth? What are you seeing out there, and what do we need to know?
Well, I've had the unique opportunity to be with youth for the last 10 years, specifically as a drug counselor. And if you look at the stats earlier, the 16 to 25-year-olds have a really high risk, but then it drops off dramatically. One of the things that I know working with kids is, and you guys have all been kids, is impulse control. Impulse control is a big thing because kids don't really drive that much. A lot of the kids, especially at Kaimuki High School, they don't have the socioeconomic to be able to drive. But if you look at like Kaiser High School, where they do, and they also have better access to drugs because they can go to their parents' medicine cabinets and get the opiates and the benzodiazepine, and they can get it for free. And they also have the money for the resources. So when you talk about impulse control compared to a population like kids at Kaiser and the higher socioeconomic versus Kaimuki High School, where they don't necessarily have the access to driving as much, what happens is they ditch school, they get high, somebody says, hey, there's a car, or let's steal a car, and then that's how they get into their driving, mishaps. I've had kids before, they'll steal a car, go for a joyride, rear end somebody, or run into a brick wall or something, and then everybody digs out. And then it's a big funny thing later, And so my job was to be able to talk to them about, what if that was your parents' car? What if that was your grandparents' car? What if there was a case where two kids rear-ended an elderly couple and ran? And they were just kind of laughing about it. And I had to say, hey, what if that was your grandparents? Like, what if your friends ran into your grandparents? How would you treat your friends? And I bust them up. I go, so what's the difference for you? So one thing is with our youth is really to give them something to do. Get them engaged in another activity that they don't have the idle times. A lot of the times, I know at Kaimuki High School, the kids would ditch school all day, but at night they would come back to the school to drink on campus. I don't know why. I'd ask them that all the time. They would sit there till for midnight, and then sometimes sexual assaults would happen. So, you know, and we're dealing with a group of kids that they have parents that have been using for years, grandparents that have been using for years. So when I see them and I talk to them for my hour or 2 hours a week, they are, and I'm telling them abstinence, abstinence, or I started switching to harm reduction because abstinence is not something that they can hear. Harm reduction, and then I'm saying, oh, well, you know, reduce your harm, but then they have parents and grandparents that they think it's legal. They honestly think that marijuana is a legal substance because their grandparents are dealing it out of the house, people that they love, uncles, aunts, parties on the weekends. So we're really dealing with a huge misnomer with the kids that see the parents and the adults in their lives normalizing it. So then they think that they can normalize it, but they don't have the tolerance or the experience to understand the negative consequences. Now, I know I'm not giving you guys solutions, because if I had solutions in the 10 years I'd have been there, I'd be making a grip of money right now on it. But really what it takes is us just to be on the kids, to be on them. And one of the most important things is talk to them like you would talk to another adult. You know, a lot of times we try to coddle them, and we just tell them like it is. I use a lot of swear words. I use their language. You know, I don't really like to do it, and it shocks other adults. There was one time where I was telling a kid, hey, you want to get high better? Some of you may have heard this story before, but I told a boy, you want to know how to get high better? He's like, what? And I go, from Friday after school till Sunday before you go to bed, how many times do you smoke weed? He goes, like 20, 25 times. I go, great. Well, I'm going to give you an idea of how to get high better and save money. He was like, really? He's like, got all excited. He's like, what? I go, so when you smoke, the first time you smoke, the next time you go to smoke, don't do it. And then the next time you do after that, go ahead and smoke. So every other time, just don't do it. And he was like, I go, one, you're going to save money because you're going to have more weed. You're not going to buy as much. And you're going to get high better because you're not getting high as often. I go, you willing to try it? He's like, yeah. So he went away for the weekend. And he comes back. He's like, mister, it worked. I was getting high better. He goes, I got $20. I can take my girlfriend out to, you know, to McDonald's. He was all excited. About an hour later, I got a call from my boss. Anthony, are you telling kids how to get high better? I'm like, did you read my notes? Did you read the progress notes? And so I was able to help him reduce his use of marijuana 50% when for the previous 3 years he hadn't been at all. So it's about how we present it to our kids, about how we talk to them. Thank you for laughing. Appreciate it. It was hilarious. It was hilarious. And he didn't realize it until about 3 weeks later, until he was smoking maybe 3 times over the weekend. And he was like, man, I used to smoke so much and now I'm not. And you know, he started to play football again. He started to go do other things with his friends. And so really getting that, talking to them like you're going to shock your daughter, is what I would say. Talk to her like you would never talk to her before. Say some things to her and really just go all out. You just the shocking factor really works with kids.
So the two things I really did like was Anthony said no car. You're not going to drive because she doesn't know how to steal a car. And you're going to play sports all year round.
Yeah.
So, yeah. And you're going to like it. Thanks, Anthony.
The harm reduction model, for any of you guys out there, harm reduction model, if you don't know about it, please look it up. Abstinence with sex and with drugs, it's not going to work. Once you taste it, I haven't met a kid that had one sexual experience or one drug interaction and never went back.
Thanks, Anthony. Dan, Mr. Stats guy, you presented a lot of stats. Do you have any, what are we supposed to take away from there besides the no aging out cohort with the meth? And, what are your conclusions from that we should take away from all of those stats?
I'm going to offer something, honestly, bearing my soul out of ignorance on my part. But I know that we have mandatory reporting from medical providers in the case of alcohol positive drivers. Does that exist for drugs, or can we extend it? Could that be a legislative?
Yes, it does.
It does.
We just don't get the reports. Medical providers hide behind the shield of HIPAA, which I'm not sure protects them. The law 291E21, if you want to look it up, it goes into great detail about people who are receiving treatment if the medical care provider knows that the person was a driver and that they're under the influence of drugs and or alcohol. They're actually mandated to report, but they don't.
I see.
And the law also provides them with shielding in the case of lawsuit that they be held harmless if they report to us as required by law. The problem is we don't get the reports.
Is there any discussion or strategy to sort of push back against that? It would seem you have some legal standing to get that. I'm just asking.
Yeah, I wish I knew. I wish I had a better answer for you, but the statute and the construction exists. It allows the courts to use it. The problem we've always had, like I said, is when we talk to hospital administrators, we get one answer, but when it filters down to the ground troop level, we get a different answer. And ultimately, the people who are going to have to report at 3 o'clock in the morning are the people who are working in the ER at 3 o'clock in the morning, and maybe not the hospital administrators. And from our point of view on that issue, it's hard to know what we don't know. So it's like the unknowns. We can't quantify how many there are if we don't get any.
Go ahead.
You know, if I could just respond to that too, and I think that, you know, to me that's a perfect example of how public health and public safety need to work together to figure out the answer, because again, you have the two kind of conflicting needs, right? You have the need to kind of maintain public safety and to follow through with you know, the laws and kind of penalties for breaking those laws, and then you have the opposite impact of you know, not wanting to further stigmatize or kind of people who are suffering from that illness. But again, I've been saying this for the last 3 years, we need to kind of cross the aisle with each other, and I think we're doing that in a lot of ways with kind of the opioid crisis and stuff like that, and I think that if we can continue to do those things, because I think, Ben, that issue to me is one that's easily solved if we really just educate people better about HIPAA and confidentiality. So, but those are the kinds of things that we should be discussing and finding solutions to.
Okay,
I
so
wanted to say a little bit about what Eddie was saying about the confidentiality. I'm not sure if you're familiar with the CFR 42 law. It's for adolescents, and basically it says that if you as a police officer comes up to me and asks me a question about a kid, I have to say I can't confirm or deny I even know who you're talking about, even if you see me talking to him, because I could get prosecuted. So there's some laws there that make it difficult for counselors to be able to disclose information, even if we were in the intention of helping, because we could get prosecuted for disclosing certain things. So there definitely needs to be some sort of understanding of where the limits lie, because there's sometimes where I would want to say something to help a kid, but I can't because I'd be giving up their rights.
it's a good challenge. So that's what's going on here locally. Now it comes all back to you in the audience on what questions you want to ask them, and then we'll direct it towards a specific discipline that we have there. And I should note, if you look at the Slido app there, you can like a question. If you see a question that's on there already, if you like it, so like at the top one, why aren't buccal swabs used by law enforcement? That got 8 likes, 8 thumbs up. So what we'd like you to do, if that's a question that you want to ask, or but it's already up there, just like it so that we know that more audience members want that question answered. So the buccal swabs, used by law enforcement instead of breathalyzer during suspected intoxication stops, since they can't identify polyuse. So police officers there, Ben, and I'll put it over to the courts, and Justin.
So in the current statutory construction is language that allows us to use that preliminary alcohol screening device I talked to you about earlier. The law also allows us to use blood or urine for the purposes of determining alcohol concentration and or drug content. The law is silent on the use of oral fluids. So oral fluid technology is something that can actually be put in the trunk of a car. There are oral fluid screening devices. They're about the size of I would say bread box, but nobody knows that is an air fryer. It's about the size of an air fryer or an Instapot. You gotta use the common terminology. And basically it sits in the trunk of your car, and you collect an oral fluid sample. It's just a swab from the inside of the mouth. There's kind of a little device, like a sponge device in there that collects oral fluids, and you put it in this device, and it'll give you a preliminary, basically a presumptive positive yes or no. The same kind of presumptive positive for alcohol through this screening. The problem is this current statutory construction doesn't allow for it, and there's a cost factor. I mean, the preliminary alcohol screening devices that we buy are in the area of $600 to $800. One Draeger, I think, Karen, it's $8,000 or $9,000. The thing is, though, the technology is developing, and the manufacturers actually want to work with us. They want samples, they want testing, they want field testing compared with confirmative toxicology at the end anyway. So the cost isn't as much of a factor as you think it might be. The current issue for us is the legislative scheme that we have. If there was legislation after this next session that allows us to use it, I think we certainly could find some grant funds and start a pilot project and see if it's something that we could use or not. But the answer is because the law doesn't say we can. Sorry.
And right next to you there, Justin, what are some legal
Well,
challenges?
Ben stole my thunder there, but yeah, he's as he often does. He's exactly right, though. The law would need to be changed, and also the technology itself is still evolving. This was kind of one of the hot topics at last year's Lifesavers Conference, which is the big annual national conference on highway safety priorities. And so we saw a number of presentations about the oral fluid, and I believe NHTSA is in the process of doing some roadside surveys and testing in different places, and so they're in the process of validating that technology for use in the field by law enforcement. So I expect we will see that being used by law enforcement in Hawaii at some point, unless a better technology springs out of nowhere. But right now it looks like it's going the oral fluid direction. It's quick, it's easy. They just got to make sure it works right, and then we've got to, like Ben said, make the law provide that we can, admit it in court and lay our foundation for it. So I think that is something a number of states are doing, and we will probably see it here in the future, especially as we see more and more polydrug usage in the motorists on the streets. They might only blow a 0.05 or a 0.0, but they're still clearly impaired. We don't know if it's heroin, meth, cocaine, a synthetic opioid. Fentanyl is in almost all of our heroin now, and we are seeing more and more opioids in our cases. So we're going to need better testing options, and oral fluid is going to be probably one of them.
Thanks, Justin. So that's question number one. So let's see, we got 9 likes on that one. The next one, wait, where did it go? Let's go to this middle one over here with 8 likes. What can school do to improve prevention education? Sorry. It was up on the top and then you moved it.
I think.
Wait, can we go to Brian first? Because the DEA over there is being real quiet, and then we'll come back down this way. Because even the DEA has some programs that you can speak to as well. Brian?
There are some programs. Unfortunately, I'm not an expert on those. We do have several speakers that go to elementary and junior high and high schools to give presentations. If you remember way back when, DARE was a huge program throughout the nation that we speak upon. Other than that, that's, like I say,
The demand
I am
reduction?
no subject matter expert
Okay.
on
So now let's go to Anthony over here. So now we did have DARE, the Just Say No.
Yeah, so DARE was a program started in '86 with Nancy Reagan and Just Say No. The results of that turned out to be more drug use.
Yeah.
Based on the DARE program. It introduced kids at a younger age and made them curious about it, and so that they went out and started doing it. Now they've revamped their program a lot since then, and so they're not in the elementary schools. They're starting to come into the junior high schools where prevention actually shows better signs of working. In the schools, junior high is the key. That age between 10 and 12 or whatever it is before they get into high school is really the key to doing it, because once they get into high school, their friends become more of an influence. So schools have less of an influence on them once they're there versus junior high schools. So that's what I would like to see, is more programs in our junior high schools that talk about prevention, as opposed to high schools need to be more about treatment.
So just so you're familiar, in Hawaii we had DARE at the 5th grade level. We had great gang resistance education and training at the 7th grade level. And there's still DARE to some limited extent. And the great program has gone to the wayside. But education certainly. I was going to say, well, let's go to pedestrian fatalities. Ben, you have anything on the current numbers? Because we're getting a lot of media this year. You drive down the highway, you see the signboards that are illuminating the number of fatalities. Tell us about fatalities and pedestrians as well as, I mean, whatever information you have over there.
Yep, and actually just looking at the app, to close the loop on the last question, there is a response, I think, from Michael Sandoval with his phone number and his email address. He said in New Mexico they have a great school-based program that comes with an app and curriculum, so just make sure you check that out. So pedestrian fatalities, I think the question was about alcohol and drug related. So I can tell you there have been 55, this is just Oahu numbers, right? I'm a cop on Oahu, so I have Oahu numbers. 55 total fatalities as of this morning. 25 of those have been pedestrians. Of those 25, I know for a fact that there have been 6 that are either alcohol and or alcohol and drugs. Gotta kind of leave it at that. But 6 of the 25, so is that 24%, 25%? The problem with statistics and the currency, the currentness of me giving you how many are alcohol, how many are drug related. If the person gets arrested for DUI when they commit the offense, the negligent homicide or the manslaughter or the failure to render aid, then we know right away, yes, we consider alcohol to be a factor, we consider drugs to be a factor. Sometimes though, we aren't going to know until way later. We get toxicology. If it's urine and we can do it on island, we might get it back in 2 weeks to a month. If it's blood and it goes to the mainland, it's several months. So until the cases get closed, the numbers will continue to rise. The number is not going to get less than 6 out of 25. The number will get greater than 6. So that's what I have at the moment for drug and alcohol related pedestrian fatalities.
So let's skip down right next, don't go away, because it's,
I see a lot
you
of
got the
these
next
different-
one there. It's for law enforcement. Why not test every driver who's involved in an accident or crash? Is it because of the medical insurance, or who determines which drivers get tested?
So if the driver dies, then they go to the medical examiner's office. Medical examiner conducts toxicology testing on everyone they do an autopsy on. So I'm actually kind of curious where the hole in the data is from FARS about fatally injured drivers, unless the person doesn't die right away. If they die at the scene, the medical examiner will do an autopsy, and with that autopsy will come toxicology. If the driver does not die and flees, we may or may not get toxicology based on if and when we find them. If they don't die and they remain at the scene, then the officers at the scene have to basically make a decision. Is the driver appear to be impaired or not? And if they appear to be impaired, then we enter into the possible DUI investigation, field sobriety test, preliminary alcohol screening, arrest. If the driver does not appear to be impaired, then they may still be arrested for the traffic-related crime, the negligent injury, negligent homicide. But unless we have probable cause to believe that the person has committed one of several enumerated offenses in the statute, and those are basically the DUI laws. If we don't have probable cause to believe that the driver is DUI, we can't compel them to provide us with a sample. So a sober person who runs over a pedestrian in a crosswalk and the officer at the scene does not believe that alcohol or drugs is a factor, or we don't have probable cause to arrest that person for DUI, chances are very, very good that we will not get a sample from that person, just because that person has a right to privacy and they have a right to their blood to remain in their body if we have no compelling government interest to take it from them.
Thank you. So with 7 likes on the education side of the house over here, what would be the best steps for schools to take to promote high-level drug education? Any resources you consider for best practice at this point? So I'll turn it over, I don't know.
Coalition for Drug-Free Hawaii has a great library. And utilizing their resources, I think, is one thing schools can do. The other thing is just to have activities for the kids, provide more. And that's a hard thing because funding is so low. But having more things for them to do that don't involve just sports. I think that's one of the things is like Kamaki School has a great Olelo program, but how many kids know about it and actually go through it? And then to get them motivated about it, we need educators that can, be able to motivate our kids to do these things, because a lot of teachers are burnt out. They got 32 kids in a classroom, 6 classes a day. They don't have any time or any energy to do that. So really, programs would work. We need more bodies. We need more bodies to come and support our kids.
Yeah, I would just throw out too that I think we need to go beyond just education, and Dixie, the ADAD branch manager for prevention, I would get in trouble with her if I didn't talk about environmental approaches, because the reality is that we can teach people these choices are bad, but if we don't role model them, if we don't have environmental protective factors that either diminish the potential that people are going to make these choices or increase the potential that people are going to make better choices, that kind of stuff. So as an example, at this point, we have created a good environment for people not to smoke in public, right? So if somebody came in here and lit up a cigarette, we would all be peer pressuring them to put that damn thing out, right? And those are environmental factors, and those are environmental perspectives that we've adopted as a society that say, this is not cool, don't make these choices. And I think we need to do more. We're getting there to some extent, and MADD has done an amazing job in helping to kind of move that. But I think we need to continue to make those efforts. When Anthony talked about when parents are telling their kids, don't drink, but they're drinking a 6-pack of beer every night, that's an environmental factor. That's a perspective that really kind of makes things confusing for kids to make better choices. And so I think beyond education, changing the paradigms of how people behave so that they can role model better, and changing the environmental, the societal kind of perspectives of what's okay and what's not okay. Is it okay to go to a bar and get completely wasted and then leave? No, it's not. Is it okay to have house parties? No, it's not. Those kinds of things that we need to kind of start to push as well.
Thank you so much, Eddie. Let's go to the next question over there, because we're running out of time, I know. So bring on the questions, because we're running out of time here. But Justin, why are so many DUI cases dismissed? Why?
They aren't in my jurisdiction, so I can't answer that question. It's defense attorneys have really figured out how to game the system to get their cases dismissed, and that's what it comes down to. You've got all these cases set for trial on the same day. Your witnesses are going to show up for a certain number of those cases. The rest of those are going to get dismissed. And it's not the witnesses failing to show because it's not a contumacious thing, as a judge would say. They're either subpoenaed to be in 3 places at the same time, and they can only be in 1 place at a time, or there's another logistical issue. They're on days off, they're on vacation, they're assigned somewhere else, and they can't be there. So those cases get dismissed straight out of the gate. And then in other cases, the defense will see that your witnesses are there, so then they'll request a continuance. And, it's very easy to put a judge in a bind and say, I haven't had the opportunity to confer with my client, judge. Going to trial now would be, a violation of his rights, or whatever the case may be. And so I need a continuance. And so the case will get rolled over to the next court date. And then we'll do the same game again of seeing, are the witnesses here? Is the state really ready to go? They'll move heaven and earth to drag their feet to the point of, putting the state in a bind to the point where cases get dismissed. And defense attorneys understand that system very well. They make a lot of money, they have a lot of cases, and if they're spending an entire day doing a trial, that's other cases they're not working on and other money they're not making. So they have a high incentive to churn through the cases as quickly as possible, just to be completely candid.
I'm not blaming, I just want you to know, I'm not blaming Justin. And JD brought up a good point that a lot of that depends on the county, the jurisdiction, the number of cases that are going through the courts. We're doing 5,000 on Oahu, and the court systems here are just congested. So it does vary from county to county. And I think it is a misconception that it's across the board. And you got to look at the individual counties.
It's a very different dynamic on the neighbor islands, because
Absolutely.
we don't have the same congestion issues, and we don't have the same volume. We don't have the same, we have one courthouse on Kauai. It's across the street from the police station. It's we have much closer communications between our agencies. It's very easy for us to walk across the street and knock on the door and say, hey, where is this guy? In the rare cases where the person isn't there. So it's a lot easier for us to get our witnesses there, to get our ducks in a row and be ready to go to trial. So it's just a very different dynamic. And, I certainly admire all the work that HPD and the prosecutors here do to try to move those cases forward because they're dealing with a very difficult situation.
I'm going to jump down over here to this question from Greg. The CDC says we have a vaping epidemic with about 25% of high school seniors vaping and 9% vaping a THC product. What do Anthony and Eddie see, and how do we mitigate this?
Yes, I see that as well. And so when we talk about the idea, so this is the thing that I keep trying to move the conversation to for myself and also for what we're trying to do in the state from the ADAP perspective is if when we talk about prevalence of a particular substance use, right, in the nation, in the state, we're always going to see prevalences of substance use go up and down, right? For us, for Hawaii, the prevalence of methamphetamine use has stayed pretty stable, for the last decade, but we've seen up and downs. And if you look at it from a national perspective and you look at it longitudinally, give me a decade and I'll give you a drug crisis, but all of those drugs have been around forever, right? So talking about the drug and the prevalence of the drug is easy, it's a good thing for us to do, but also talking about why is it that people still continue to want to get high? Why do people continue to want to use some sort of mind or mood altering chemical in their lives? How many in this room, I won't tell you to raise your hand, but think about it. How many of us in this room in the last week or so had a few beers or had a few glasses of wine? There are reasons why we continue as a society to want to do those things, right? Those, not to say that everybody's going to become addicted, but those are all risk factors. And in terms of how we mitigate it, we have to start to change how we look at this illness, how we look at this disease, and how we respond to it. Because if you look at how we respond to substance use disorders, both in the prevention arena and the treatment arena and the recovery arena, we respond to this disease very, very differently than how we respond to any other disease in our nation. If you think about the responses that we have to cancer, the responses that we have to diabetes, the responses that we've had nationally for HIV, those kinds of things, it's very, very different than how we respond and think about the disease of addiction. And that means universal screening, right? My dream would be that everybody that walked into a doctor's office would have some sort of risk screening about just general substance use risk, those kinds of stuff. And I'm ranting at this point, but you see what I'm saying is the prevalence of the actual drug, we do need to continue to kind of collect that data, but the question is, what do we do? The second part of Greg's question is really, really important. How do we mitigate those prevalences, right? And the only way that we're going to do that is if we start to change our paradigms and our approaches in terms of how we address this as a illness, as a chronic illness.
So I don't mean to interrupt, but Anthony, you got to wrap it up. Last comments.
Yeah, vaping. This one is really important because this one, there's no long-term studies. More young adults are showing up in hospice because of vaping than ever have before. 30-year-olds are in there for cancer and ending life. There was a kid that I had, 18 years old, senior in high school, was having erectile dysfunction from vaping. 18 years old. And so this is something that hasn't been studied. We don't know about it, but it's a healthy alternative. Again, vaping is a big deal, and a lot of people think it's a really easy one. How to mitigate it? There's not enough research. Again, it goes with impulse control, what I talked about, is you have to do it on an individual basis versus a big thing, because once you give a big picture of it, people that don't do it are going to be interested in it. Versus if you just target the people that are actually doing it and then saying, hey, look, here are the risk factors. I think that would be a lot easier way of doing it.
So I know there's a lot more questions, but we're out of time. Our panelists will be around, but can we give them a round of applause for their participation today?